Well, thanks everybody for coming today. It's a privilege to be here today with Minister Osborne and Dr. Kris Luscombe, the President of the NLMA. And we all recognize the challenges that are facing our rural and remote health centers in particular. And several weeks ago, the NLMA and I sat down and discussed some potential short-term solutions to help with ongoing staffing issues in some of these, what we call Category B sites, so emergency departments that are not necessarily in an urban center around the province. The NLMA came with potential solutions, and I'm happy to say today that we've acted on those solutions. And so we are going to, in the short term, provide some immediate incentives for physicians working in those Category B sites, and hopefully look then towards more long-term solutions. So with that, I'll open it up to questions, and Dr. Luscombe, myself, and Minister Osborne, I'm happy to answer any of them, and of course, happy to answer any other questions on health. I know it's top of mind. I just had a meeting with Minister Duclos off the heels, of course, of the first of the COF meeting. It's top of mind in every province, and it was certainly a pleasure to meet Minister Duclos and express Newfoundland and Labrador's opinion on the healthcare system moving forward. Well, I don't take that as a criticism, frankly. I think, sometimes you need a Band-Aid. You need to stop the bleed, and then you need to move forward. So, and in the acute issue at hand, I think incentives is one of the levers that we have to help stop the bleed. We are working on medium and long-term solutions. There's no question. That will take some time. Training a physician takes time. Recruiting physicians around the country and from international communities takes time. We're working on all those strategies collectively with our stakeholders to ensure that we're all aligned. There's no one in here who, in this building, or any other building, I would argue, across the country, who is saying, now how can we cancel surgeries today, or how can we close emergency departments? Quite the contrary. We're seized by trying to eliminate barriers to allow Newfoundlanders and Labradorians to get access to care. So sure, a Band-Aid solution, but sometimes Band-Aids are needed in the short term, and that's why we followed the NLMA's lead. This was brought to us by the stakeholders and acted on it in short order. Well, I can tell you. I guess to move away from the medical analogy, what we want to do is try to stabilize the system in the short term. This is one of very few levers that we have available to us. And again, a solution proposed by the stakeholder, by the NLMA, representing their physicians as a potential solution. And so we acted on it. I do think, perhaps a Band-Aid or a suture, perhaps we'll litigate the bleeding in the short term. But again, you've heard me say before, and I was encouraged by some of the conversations I had with the other premiers that we have, despite the challenges of COVID-19, given some thought to the long-term sustainability of the healthcare system, and we did so with the Health Accord. And I can tell you some other provinces are wishing they had that foresight. The other thing I will say is this. Some people have said, well, what have you been doing for the last 2 years? Well, we've all been seized by COVID-19, and the downstream impact of that now, unfortunately, is coming to fruition. But the entire health system, including the Department of Health, was entirely seized and captured by providing public health and safety during the pandemic. We're moving to the next stage, and our government is fully seized with that challenge and equal an opportunity moving forward.
Premier, recognizing that this can't be fixed overnight, this initial solution would be incentivizing. How quickly do you see that starting to show?
Sure. Yeah, hopefully very quickly. I mean, I had a conversation with a physician in Bonavista yesterday on the phone, and this was one of the issues that she raised. So, hopefully this will address some of her issues in terms of being able to predict and plan with respect to her own, their own financial situation, and will incentivize her and others to stay in the Category B site. So this is, the NLMA is right, this is top of mind for physicians who are working in these Category B sites, and it's complex, challenging work. I had the benefit of having a full hospital around me in a tertiary center. Some of these people are out there dealing with everything from coughs, colds, to motor vehicle collisions, to, neurosurgical bleeds in a remote area. And I think the challenges that present deserve different incentives, and that's why we acted in concert with the NLMA today. But to your point, I've heard that this was an issue, not only from the NLMA, but from physicians themselves, and hopefully it comes as this news today will come as some relief for them, but will also show that the government is acting.
Can I just dovetail that with the
Sure.
NLMA, as a matter of fact? I know that historically, NLMA and government Department of Health have been active in the past, and there has been a long effort, and I know on probably both sides, but yours certainly, to get these conversations going again. Do you feel satisfied with this first step?
I mean, this is very positive. This is a reactive measure that was put together very quickly to solve an on-the-ground problem. And the funding, of course, will now make these Category B hospitals, these places, I'm from rural Newfoundland, these places are very close to me personally. It'll make them much more attractive, and in particular, it will also compensate those physicians that have been doing this difficult work. They will now benefit from a much more valuable compensation package. So it really signals to me that that there's a demonstrated value for that work, and a commitment now to make these places much more desirable, sustainable, and to reward those physicians that are doing the work. So I think also, this makes us a lot more competitive when you're trying to identify Newfoundland as a place to come and practice. So we recognize that all of our physicians currently are working very hard and don't have a lot of additional capacity. But when you start valuing and compensating these locations adequately, then it starts sending a signal nationally that we're open for business and we're a good place to work and we want to be competitive. I wouldn't be able to give you the specific details except to say that there was a pretty big variance in terms of how busy an individual might be. This gives some guarantees. It allows options for working like half shifts even. And so it makes the compensation much closer to what would be like a Category A emergency department. So Category B emergency department is staffed by family physicians, and they don't have the on-site specialists. They don't have the same level of backup as a Category A, which would be St. John's, Grand Falls, all the larger sort of sites. So this, one can imagine that that's a pretty challenging job. It requires a very broad level of expertise to service this, and this brings it relatively close to the compensation of Category A, and makes it a lot more desirable as an option to work in.
This announcement today is sort of specific to rural. Can you speak to the pressures that are on emergency room doctors in the larger hospitals, such as what they're seeing, what they're hearing right now around St. Clair's, Health Sciences, the larger hospitals, those large emergency rooms that we're hearing some very difficult stories about?
As the Category B emergency departments struggle, then of course that work cascades back onto Category A. It spirals through the entire system. And we are hearing that physicians in all the emergency departments are feeling a very heavy workload. So it becomes very important that we think about all the ways that we can help prevent things from ending up in those larger centers. And one can imagine if the Category B sites are well staffed, then this is going to have a very positive impact. Patients can get the care, where they need it, close to home. We're not having to depend so heavily on patient transportation. We're not having to, as you can imagine, individuals are going to be less likely to be, putting off their care. You put off your care, and then all of a sudden it becomes a major catastrophe that can only be handled in the emergency department. So it is fair to say the entire system is strained, and we have to think about all the different ways that we can have all of our service providers, including physicians, increase capacity, increase availability, and that will ultimately help those larger emergency departments. In the Category A's, as an example, I think that there are a range of activities that are ongoing like virtual ER is a good example. So we have some different services that will allow these sites to continue to get some service if they are not completely staffed. We have met with government over the last week in particular, and we have identified a full agenda for family medicine that we are currently discussing with the government, hopefully something that we can come to an agreement around, because as you say, this is not going to be the solution in itself. And the NLMA identifies approximately a couple of dozen items that we've had some discussion with the government about. Some are in progress, some are some newer initiatives, and we're hoping that fairly urgently we can come to an agreed agenda so that we can continue to put urgent pressure on, or urgent attention, I should say, on many of these other issues that will help with that. In terms of compensation? Again, I wouldn't be able to speak to the exact particulars around that. It's something we can get for you.
Might be able to provide more specific details.
Okay. I'd like to answer a question that Brian had asked as well, but I don't want to complicate it too much, but in ballpark numbers, we're looking at $800 a day, which would be $400 during the daytime hours, $400 in the evening hours.
That's additional.
In addition, over and above. In some of the other locations stacked on that would be another $300 a day, $150 during daytime hours, $150 in the evening. I know that the formula itself is somewhat complicated. That is as simplified as I can make it for you. Different sites will have different scenarios. In terms of one of your questions, and Dr. Luscombe not wanting to reveal all of the details, and I respect that and appreciate it because we don't negotiate in public, but we are looking at things in terms of a very collaborative set of discussions with the NLMA on things like international graduates, on recruitment and retention. As you know, the Premier's already put in place an Office of Recruitment and Retention. Just last week I added additional staff in that office, as well as additional resources at the health authorities to help with recruitment and retention. It is one of the top priorities. We're looking at virtual care in certain areas, especially in areas such as Category B. Without going into any further details until government and the NLMA iron out those details, I can say that we've had very positive discussions, and I look forward to working with them on finding those resolutions.
So that's an impossible question to answer, right? 45 patients is too many, and we're working to do better. But any given day is not a normal day in any emergency department. So it's really hard to kind of benchmark. But we are committed to improving the services at the health science. You see a new health science emergency expansion, for example, being built. I talked to a seasoned emergency room physician there this morning about feedback. Minister Osborne has already kind of reached out. There are creative ways within the system to help improve efficiency, but I think what Dr. Luscombe said can't be understated either, and that if Category B isn't well serviced, then they have to go somewhere, and so they're going to Category A. So, incentives like today will help take some of the pressure off. Will it be a single fix? No. There's no single fix to all these issues, or else we would have done it. I mean, so building the infrastructure, creating human resource capacity, whether that's expanding by 5 at the medical school or expanding the nurses school by 25%, all these things take time. And whether sometimes in the absence of immediacy, you need some Band-Aids, and that's why we have incentives like today to help while we're planning for the medium and long term, and there'll be more to come in the future. But this is just something immediate today that we need to do. We've talked to the stakeholders, but benchmarks, they're out there, but there's no God love the people working in the emergency departments, the nurses, the orderlies, the physicians. They're amazing people, and they take whatever comes in. I mean, I was very fortunate to only have to deal with something, and it was all packaged up, and they had already seen them. And they deal with whatever comes in. Them and the paramedics are real heroes in the system, and we're there to support them. We want to hear their solutions. It's no good for us to come in and say, well, we think you should do X, Y, Z. You tell us what you think we should do, and that was part of the conversation today, and we'll try to action it through the health authority.
So Canada just approved the vaccination, COVID-19 vaccination for under 5, children under 5.
Yeah.
Kind of reaction.
I think it's great. Yeah. Well, hopefully it'll mean that we continue with leading the world with vaccination rates, particularly in the pediatric population. Newfoundlanders and Labradorians have stepped up like none other across the country and around the world, and this is yet just another cohort where we have the chance to lead the world.
You see the world is coming for people over 50.
Yep.
Second booster. Do we expect a quick rollout for under 5?
A quick rollout for under 5. I mean, hopefully. The details of which haven't been released yet, and I don't think they're finalized yet with respect to under 5. I mean, we used, I think what separated us from some other jurisdictions with respect to the 5 to 16 or whatever that population cohort was we used the schools, where some other provinces didn't use schools to access vaccines for COVID-19. Hybrid model of using schools in the mass vaccination clinics. And so I'm confident that our team will use creative solutions to ensure that all those who want access to the vaccine can. And it's a great opportunity for me to say that anyone out there who hasn't got who hasn't got their up-to-date doses should. Yeah, go ahead.
Andrew Furey spoke yesterday, and I think many people left the impression the federal government is interested in increasing funding for
Yeah.
health care funding in the province.
It only took a meeting in Victoria for that.
It's long to actually do it. I mean, are you discouraged or are you concerned with the pace that they haven't announced they're actually going to do it?
No, I'm not discouraged. I think that this represents an opportunity for us to work together. Canadians, Newfoundlanders, and Labradorians who are waiting in emergency departments around the country right now, they don't care about who provides the funding. When I've had to cancel a surgery, the patient doesn't care whose funding is responsible. What they do care about is maintaining a Canadian level of care, which we've all been proud of, we've all celebrated around the world, and in a modernized system into the future. So I was encouraged today by Minister Duclos and frankly by Minister LeBlanc, who after the press conference said that they were prepared to come to the table with funding. And there's none of us that are naive. There's plenty of room for debate about the calculus of the funding and the so-called outcomes and results. But, when you're punching in the air, you're just shadowboxing. We need someone else on the other side to actually have those discussions, and so that we can move forward collaboratively to reset and reimagine the system. Because the system it's not unique to Newfoundland and Labrador. All the stories are the same. Like on all your web pages, by the way, that if you look nationally, it's the next one after Newfoundland is somewhere else, is somewhere else, is somewhere else. That means it's a Canadian problem. It's not specific to Newfoundland and Labrador. We're in charge of Newfoundland and Labrador. Items like today are things within our wheelhouse that we can action, but it deserves Canadians' demand, and they should have a federal conversation. And I was encouraged today that Minister Duclos was open for it, and Minister LeBlanc and his comments are open for it. And we need to move beyond the finger pointing and the rhetoric and get down to the details.
We've only got a second left, folks.
Yeah.
What happens after October, and what is the estimated cost of this?
Well, I guess it depends on how many people avail of it. But after October, again, this is a short-term fix, and we'll have those conversations as we move closer to that date.
Juanita, you had a question?
Just a specific one again, sorry guys, to talk me, but
Yeah.
who exactly is getting this compensation? Like, is it just physicians, but not nurses?
Yeah, we're working with the nurses. Like, I mean, the healthcare system obviously is supported by incredible Newfoundlanders and Labradorians through many different cross disciplines and cross specialties, and they're beautiful people who are working hard every single day. And, you know, this is specific to physicians, but we continue to work with allied health professionals to meet their needs, and have had great conversations with Ms. Coffey and the Nurses Union as well. I know, met with the head of the Canadian Nurses Union Federation in Victoria. Again, the stories are consistent throughout. Surprisingly, actually, to some respect, that, you know, the same issues of scheduling, the same issues of work-life balance, of a changing paradigm shift of how nurses want to practice moving forward. And so, you know, we're having these conversations with Ms. Coffey. I think, you know, a good move, a good show of collaborative effort was to have the think tank, which was earlier this year, and now to action some of those items collectively, I think is where we're headed. But stay tuned for more details.
Yeah, so it's not just this year that these emergency services in rural areas have been divergent or closed temporarily. But do you think that it is possible to sustainably keep all these open, or do you think there will have to be decisions made about closing some of them?
No, our efforts are focused on sustainable solutions, and I think you've heard a combination of different elements of that here today. You know, we've seen a huge uptick in 811 use, for example, which does diminish the utilization of the emergency department. Virtual care, virtual support. So I would argue that, you know, some of these sites, despite not having the subspecialty support system that a tertiary care center would have an opportunity right now to access virtual care, which, you know, a decade ago wasn't there. So they were literally the only person treating the patient a decade ago. But as we invest in infrastructure like broadband, infrastructure like virtual care, this will allow these sites to potentially be more attractive. And I will say that, because it came up briefly, and I just want to touch on it, the NLMA and myself, the Minister, the College of Physicians and Surgeons of Newfoundland and Labrador, and Memorial Medicine met last week to look at creative solutions for these centers as well, specifically as it pertains to international medical graduates, so-called IMGs. We've used IMGs in this province for decades. They've served the people of Newfoundland and Labrador very well, but it's the perfect storm of a changing way to practice, new mechanisms of licensure, and then coming out of COVID-19, which has led to significant strain in these Category B sites. So looking at how we can help eliminate some of the barriers for IMGs while maintaining the standard of care is important to us. It's important to the NLMA, and I think, you know, we had great alignment in that meeting. There's some barriers that we can look to eliminate, some efficiencies that we can have there, whether the doc is from the Ukraine or from somewhere else around the world. We want to make sure that we give them the access to the training they need to be able to stay here and work here and do so in an efficient way. And that was a conversation also in Victoria as well, looking at a national license for mobility purposes across the country.
So how much influence do you have in the college, and are you looking to bring back the program that invited people on provisional licenses and then brought them up to case standards?
Yeah, we do have a good program in place right now. It's being run out of MUN Med, and they're doing a great job. I don't think we'll go backwards, because that's a national standard issue, as I understand it. But there are there are a series of steps with the college, and then with the education piece, and then back to the college, that we can tighten up efficiencies on. Of course, we don't, we're not involved in the day-to-day of that, but there are efficiencies that can be had there. And I think collectively, I mean, Kris, you can comment here, there was a real willingness at that table to figure out, okay, how do we advance this? How do we make sure that this is moving as efficiently as possible? Some of it will be funding related, and we're prepared to invest in that. but some of it is just actual bureaucratic efficiencies. And they're feeling that across the country in terms of licensures from outside jurisdictions. And frankly, as Canadians, we need to be better at it. We need to eliminate some of the red tape. And we've shown we can do that, by the way. There are barriers for me to go practice medicine in Ontario, for example. All those barriers went away when COVID-19, when we sent doctors and nurses up to Ontario. So if we can do it in COVID-19 and the license is good at that point in time, why can't we have a national standard of licensure so it will allow for mobility? And that, by the way, is part of the things that is attractive to young people practicing medicine now is to have that mobility, to be able to, okay, I'll go practice there for 2 months and go practice there for a couple months, and to have that Canadian experience. So we are looking at efficiencies, and certainly seem to be all well aligned.
Thanks, everyone.
Thank you.